Good morning. My name is Sudarshan Shetty. I'm an associate professor at the University of Minnesota. I would like to thank the organizers, Dr. Muralidhar Kanchi, for giving me this opportunity to speak at this conference. It's a privilege, like always. Kudos to them for having organized this in the middle of a pandemic. My topic for today is echocardiographic evaluation of the right heart in the perioperative setting. So there's like more modalities than just TE that even us as cardiac anesthesiologists get involved. I have no conflicts of interest. Objectives of this study will be a brief introduction about the right ventricle and a few modalities to assess the right ventricle, non-Doppler, Doppler, using the epicardial ultrasound, and we will talk about some interesting TEEs that demonstrate RV dysfunction. How important is the right ventricle? When I was in med school, we were all taught that RV is like just a passive conduit, and that remained the popular notion till the early 2000s. But now we are realizing the importance of this chamber and why it's important more so in the perioperative setting for us as cardiac anesthesiologists. After cardiotomy, the RV failure rate is about 0.1%. That increases to about 3% after a heart transplant, about 30% after LVADs. And not surprisingly, acute RV failure is associated with high mortality. What are the differences between the two ventricles? Why is it the RV is more susceptible to damage? As you can see here in this slide, the thickness of the right ventricle is smaller. It's got a much higher volume, higher compliance. It adapts better to volume overload states as compared to pressure overload states. And owing to a lot of like the anatomical peculiarities, it's much harder to manage if it fails in the perioperative setting. So some of the other characteristics of the RV. How does the RV contract? We all know that the left ventricle has like a twisting and rotational motion, and that's how it empties out the blood inside the chamber. The RV has like three different mechanisms. There is contraction of the free wall moving like bellows. There is longitudinal shortening of the ventricle, and there is contribution from the interventricular septum, which contributes, depending on where you look, between 20 and 40% of the right ventricular ejection fraction. This is a 3D image of the right ventricle and the left ventricle. Column A is the left ventricle and a normal looking RV. So you have the tricuspid valve here, and the RV wraps around the left ventricle, and that's the pulmonic valve. When the right ventricle gets enlarged in any kind of like disease state, you can see how the tricuspid valve, the relationship of the tricuspid to the mitral is altered there. The chamber is like hugely ballooned out. And even though it's wrapping around the left ventricle, the shape is changed. And here you see subtle signs of interventricular dependence, where the interventricular septum is pushed out to the left ventricular side. I would like to draw your attention to like a couple of important papers for assessment of the right ventricle during the perioperative period. Both are from Anesthesia and Analgesia in 2009. Some of the information here in this talk will be presented from these two papers. How do you identify the right ventricle? This is not something that we have to deal with. We don't even think about it like when we take care of our patients. But the classic representation of what a right ventricle should look like and how do you identify that is as follows. It should have more than 2 papillary muscles because the tricuspid valve, as the name suggests, has like 3 leaflets. There should be a moderator band, and there should be an apical displacement of the tricuspid valve. That is when you know that you're dealing with the right ventricle and not the left one. Functional variables of the right ventricle. It's a busy slide. There are systolic performance variables, diastolic parameters, and something that combines both the systolic and the diastolic. And there is also like think about load dependency. And if you use the one that has the least amount of like load dependency, that will be the IVA. I'm not going to like elaborate too much on some of these parameters because we don't use it on a day-to-day basis, and we have time constraints for this talk. So some of the focused RV views from the anesthesia analgesia paper. This is like part of the routine exam that we usually do, the upper, mid, lower esophageal to transgastric and the deep transgastric views. Now let's take a look at the non-Doppler assessment of RV function. This is mostly the linear measurements. In TEE, when you look at the linear measurements, it's usually in the 4-chamber view. And as you can see in this cartoon, there's like 3 dimensions you measure. One at the tricuspid annulus, and the second measurement is going to be where the tricuspid valve leaflet, when it opens, meets the free wall of the right ventricle. And the third dimension is kind of perpendicular to these two. These are the reference ranges. And if you have to like remember like just one number, anything more than 4 centimeters at the tricuspid annulus is severely abnormal, and anything more than 9 in D3, that's the one that runs perpendicular to the other 2 measurements, is considered severely abnormal. Now, this is a TTE. I put this up here because it demonstrates the apical characteristics of the right ventricle. If you see here, this is a brisk right ventricle. Even though the apex of the LV is not very clear, you can see the right ventricle kind of meets the left ventricle about two-thirds of the way. And the left ventricular apex is almost completely formed by the left ventricle. What happens with RV enlargement? The formation of the apex is kind of shared between the two. And as you can see here, so that's the left ventricular apex. This is the right ventricular apex. And you see the RV is almost as big as the left ventricle. And that's the shared apex. More measurements. Now, at the level of the annulus, it's more than 4 centimeters. We said it's severely dilated. That is what this RV is doing. And even though it's like 8.35, that's almost 9 centimeters. And this is also a severely dilated right ventricle. More linear measurements. You can also measure the RVOT just below the pulmonic valve and a little below that. And you also measure the main pulmonary artery. And here are some values for that, where it's considered severely abnormal. That's measurements in real life, RVOT 1 and 2. Now let's talk about the eccentricity index. This is kind of peculiar. We are looking at the left ventricle and saying if the right ventricle is normal or not. So what is the eccentricity index? It's very simple. If you take the anterior-posterior, LV anterior-posterior diameter and divide that by the LV septolateral diameter, and if it's normally it's 1, if it's more than 1, then it's abnormal. And depending on if it's increased only in systole or systole and diastole, you can kind of differentiate if the overload for the right ventricle is volume or pressure. Here's a eccentricity index. That's the anterior-posterior diameter, and the septolateral diameter is 1.1. That's close to 1. So this is almost a normal RV. So the ventricular interdependence, depending on like when the interventricular septum is compressed, that's your interventricular septum here, RV and LV. So you can see that if the RV is much bigger and pushes the interventricular septum towards the LV only at end diastole, it's more likely to be volume overload versus pressure overload. The coronary sinus. This is something we usually see when we have to like place a coronary sinus catheter for delivering cardioplegia. Why is this important here? The bigger the coronary sinus, it has been related to RV function. There's an association of coronary sinus diameter with pulmonary hypertension. Bigger the coronary sinus, worse the pulmonary hypertension. All right, so here's an image of a dilated coronary sinus. And as you can see, like each of these dots is like about a centimeter. And if you measure the coronary sinus like just about there, it's about like 1.2, 1.3 maybe. So we saw a dilated coronary sinus and we had a left-sided IV and we injected some contrast and you can see that coming through. Patient also had a left persistent SVC. Other parameters for measuring RV function, fractional area change. We do this all the time with the left ventricle. So can we apply the same parameters for the right ventricle? If you see the geometry of the right ventricle, it's very different from the left ventricle. So you're assuming like much more if you use fractional area change, but there have been studies that have looked at this and it correlates pretty well with RV function. So here is the RV area in end diastole versus end systole. And if you take the distance between the annulus and the tip of the right ventricle, between end diastole and end systole, the difference would be a TAPSE. So you can like get two measurements at the same time. So here's calculation of the fractional area change in the 4-chamber view. So what we found is this is a dilated ventricle and the fractional area change was 19.1, which is clearly abnormal. So can you look at the RV in 3D? For sure, you can. The right ventricle is an anterior structure, and as you can see, like it's very hazy, and you can see only a cross section of the right ventricle instead of the whole thing, which is a limitation. What if we use the same software that we use for the left ventricle on the right side? We can do that. So instead of the jelly bean, as you can see here, we're missing a big chunk of the right ventricle, and this is why it's going to be inaccurate. So far, I'm not aware of any advancements where they're using 3D EF calculations for the right ventricle. How about TAPSE? TAPSE is an old tool, but it can be like important measurement. There is a lot of inter-observer and intra-observer variability. It's pretty simple. It is load dependent. So here are some advantages and disadvantages of that. So TAPSE and measure TAPSE. So we kind of like went over the measure TAPSE. So measure TAPSE can be used instead of using TAPSE in the classical sense, in the what we see in the TTE. Okay, some Doppler-based measurements. So it can be used to measure the myocardial velocity and tissue Doppler. So there's a few parameters here. I'm not going to go through everything in detail. The right ventricular myocardial performance index is kind of load independent, and it will tell you both diastolic and systolic functions of the right ventricle. Here's the RVS prime. That's the RV MPI. And anything, so 0.28 plus or minus 0.04 is considered normal. So you can also look at the RV diastolic function, look at the RV inflow velocities, hepatic venous flow, and the tricuspid annular tissue Doppler. So that's the IVC diameter, and hepatic venous flow, the S and the D. Normally S by D is more than 1. So here's like severe TR from like a dilated ventricle. So the right atrium, it has to be assessed in like multiple views. And the interatrial septum can be used as indicator of right atrial pressures. As you can see here, it's bowed over to the left side, which indicates that the pressure in the right atrium is like much higher than on the left side. Intraoperative epicardial ultrasound, it can be a useful tool. And there are a number of views where you can actually look at some of the right-sided structures like the RVOT there, RV there. That's the RV, RVOT again the RV here. And you can also look at the main pulmonary artery along with its branches. So let's move on to like some interesting TEEs that demonstrate the right-sided dysfunction. So here's a patient who came in for a BIVAD. And as you can see, both ventricles are not moving well at all. The right ventricle is clearly dilated and the function is like obviously like low. And you can see some hardware that's the CRTD in the right ventricle. So this was pre-cardiopulmonary bypass. And as you can see, like that's a dilated ventricle. So yeah, so this is another patient with severe pulmonary hypertension, and this is an intraoperative echo. So as you can see, like this is the RV, it's thick. Anything more than 5 millimeters is considered like a thick RV. Once the lungs were transplanted, the pressure against which the RV was working came down, and you can see the RV thickness is exaggerated, and that's just trying to measure the RV thickness. So each of these dots here is a centimeter, so this is about like 3.5 centimeters. Clearly a very thick RV. This is a patient who had like came in for a left ventricular assist device, and the RV was like not very snappy, but it was okay. It was like probably moderately dysfunctional. There's moderate amount of TR. Patient had a prior cabbage, and when they opened the chest, they inadvertently damaged the coronary arteries that were supplying the right side. And post chest opening, this is the RV. It's more dilated now, and you can see the interatrial septum bowing to the left side, which tells you that the pressure in the right side is much higher. And even though you don't see the TR worsening, this is clearly a right ventricle that's struggling. This is a patient with infective endocarditis. You can see like some Goomba like floating around on the left side, and the right side, even though it's like not too bad, it's clearly dilated. And this is the same patient after they had to replace the valve. I'm sorry, I think I'm going the wrong direction. So the valve was replaced, and this is post-op TT with improving RV function. Intraop though, after, I'm not sure like why this is not playing. Intraop after the valve replacement, this is how the RV is. It's barely moving, and this is like a kind of a stunned RV. Many reasons why the RV can behave like this, but it did improve like post-op. This is a quiz for everybody. So if you look at this picture, like this image or this video, the left ventricle is like struggling, but if you see, the right ventricle is like really snappy. The reason why the right ventricle is so snappy and the left ventricle is not is this is like peri-CPR echo. So this is CPR with the Lucas device. So this clearly shows you the anterior right ventricle, the amount of compression that happens with the Lucas device while you're doing CPR. So in summary, RV is a complex structure and not easy to assess by TE because of its more anterior relation to the chest wall. We have a number of parameters that we can use to assess the RV function, but a combination of qualitative and quantitative parameters is used in the perioperative period. Mostly it's qualitative and maybe like a couple of the quantitative ones, the TAPC or the measured TAPC, the fractional area change. If I had to choose two of them, I would use the measured TAPC and the fractional area change. And that's my talk. Any questions?